Hey, it's Ryan with the Standard Care Briefing. I'm here with Mike Martinelli. It is a hot Thursday in July. The biggest drug dealer you've never heard of had to go before Congress recently, and there's some interesting updates there. AI, which is everybody's favorite topic, is about to get even more insane. And we're going to share with you a recent academic paper and some forthcoming product updates from Microsoft that convinced us. And then we're going to close out with a few quick policy and political updates on both payer stuff and then some health record sharing stuff. So to kick it off, not technically drug dealers, but pharmacy benefit managers are a thing you've probably never heard of, but a way to think about them is on the Fortune 100, there are no pharmaceutical companies. There's no pharmaceutical company that's big enough to be in the Fortune 100, but there are drug distributors on the Fortune 100. Being the middleman between you as a patient and the pharmaceutical company is big business. It's hundreds of billions of dollars of revenue. Or let's see, CVS, Aetna, and some of these, these other companies are,
Yes. And I really was thinking about it in the context of like how I interact like with the pharmaceutical industry in terms of if I have to get medication from the pharmacy, and then if like taking a step back and thinking about it, you have insurance that will cover some of the costs. There's those coupons out there, like GoodRx is a great example. And I was thinking about reading this article, like so first of all, how much does it really cost to produce your a typical generic drug like a statin? And then I'm paying, say, for example, $20 out of pocket if I'm using my insurance for a generic drug. How much does the actual drug cost without insurance? If you look it up, it's probably hundreds of dollars, even the generic drug. Who's getting paid? Is it like, say, we're talking about a drug that's made by Pfizer? How much of that is Pfizer getting? And then I didn't even realize that there's these middlemen distributors. So you got El Chapo, I forgot which drug they were talking about for a sec, that are really, that's where a lot of the money is going. And when we talk about, middlemen in different kinds of industries, if you chop out that middleman, then you're really going to reduce costs. So it makes sense why drug prices are, the way they are being so high, because there's so many different parties involved in the whole distribution, manufacturing, and then where the money's going. So
you have the classic using my own childhood as an example. You have single mother of two, and my little brother had asthma, and there's this question of like certain drugs, like how is the list price so expensive? And if you get caught, if you change jobs, and all of a sudden that drug you need is much more expensive. Or maybe your employer just changes plan. Maybe you didn't leave an employer, but they change plan, and the pharmacy benefit changes, the drug price jumps. And the inhaler goes from $20 a month to $500 a month or whatever it is. Those shifts around in pricing have to do with these distributors in the middle, and they provide valuable services in terms of contracting, pricing, and then the physical distribution, getting the drugs from Pfizer, Merck manufacturing site down to your local pharmacy and into your hands. But what's going on here, or what Congress is like catching up, within the healthcare industry, these folks get a lot of scrutiny and a lot of ridicule. Congress is a little bit late, I think, in catching up with this. And it's very popular also. So it's kind of a bipartisan thing. Both Republicans and Democrats are digging into it. If you've been to the pharmacy recently and you've tried to use GoodRx, like your example, Mike, it's why is there such a difference between pricing with a coupon or not? That's are digging into it. If you've been to the pharmacy recently and you've tried to use GoodRx, like your example, Mike, it's why is there such a difference between pricing with a coupon or not? And a lot of it are these rebate games that are going on, and the idea is people may not use the coupon. So if the drug company issues rebate for 100 people, but only 20 or 30 people redeem it, then the drug company, the distributor, the PBM in the middle, the pharmacy all can realize that higher price. Let's say it's a 20, whatever it is, $500 without the rebate, which is beneficial for everybody, pretty much in the middle of there. This article did point fingers back pharmacists, particularly independent pharmacists, back on PBM managers. And there's also a question of vertical integration, meaning one large corporation doing everything. So in this case, it would be negotiating the wholesale prices from the drug companies, negotiating the contracts with the end user pharmacies, and then critically, the thing that's hard to reproduce, probably the hardest thing to reproduce, is actually moving the drugs around. So it's a regulated supply chain, moving the drugs from New Jersey or wherever they're made through the interstate, through whatever, to all the different thousands of pharmacy sites in the country. So that gives them a lot of power because they're offering this logistical support to get the drugs out there. But the critique is that it's being abused and somehow needs to be revisited.
Yeah.
This harkens back. We had talked a couple weeks ago about Medicare's attempts to negotiate drug prices for all of Medicare and how that looks a little bit like a European system. And Merck was actually going in to sue the United States federal government in order to prevent that from happening. So just like everything in healthcare, it's very political. And I think the pattern that makes me most angry is if you're a consumer and you're strapped on time because you don't have resources due to low income or just high stress in your life, then you are the person who's unlucky and gets kind of screwed over by these things. But if you had enough resources to do to look up the rebate, remember to use it, go to the right pharmacy, make sure you're getting the right version or brand of the drug to use the rebate, then you can get the effective pricing. And that differential experience is uniquely, it's very, for a modern economy, it's uniquely American. I'm surprised that we're still dealing with this stuff, but it's good that it's getting scrutiny now. Who knows how long it'll take? Congress, I don't think, is ready to do anything. I'd be surprised if more than 10 people in Congress could accurately describe how this stuff works. And that's not a knock against them. It's a giant black hole of money and complexity, and it's a lot bigger than I think people realize. People take for granted that they get a drug when they go to the pharmacy. That just seems like any retail experience. But what's going on behind the scenes and the high value of this stuff is really tremendous.
But don't forget to account for usually things like in Congress, if there's a bipartisan agreement on a certain policy issue, which is rare, but if there is, those things tend to move faster through Congress in terms of being made, written into a bill. In this case, very an industry that has a lot of money. So we're talking about not just the pharmaceutical manufacturers, but the distributors. All in all, the lobbying power that they have in Congress is what is slowing this down. Because they have so much money, they have enough money to get representatives to back off and push more industry-friendly legislation.
Yeah. So let's make a prediction for the 2024 election, Mike. Will PBMs be a talking point on the debate stage for the general election?
I'm going to go with a no here because this is a bipartisan issue. When you're debating it, you want to make yourself be different from your opponents. So if I did some more research on it, and there's two really major approaches to this resolving this PBM. So it's two partisan approaches then I'd say, okay, you'll see that come up on the debate stage. But if we're just talking about this overall thing, I don't think you'll see it on debate stage.
Okay, so that we might expect both presidential candidates to have something about this in their platform. It'll probably be buried, under healthcare, under behind insurance,
Yeah,
under drugs, because it's like a detail under drugs within healthcare policy.
here's how I see this playing out. It's a bipartisan issue. It's something that hits home. It really affects every day at your average citizen. Not just people living paycheck to paycheck, but you have tight finances. I could see them putting up legislation in the House, and then without the intention of really passing it, given the lobbying interest there, just so they could say that on their campaign ad, oh, I signed this bill, I contributed to this bill in the House to reduce prescription. It'll probably go before Congress, go to Congress before the election, so that they could just say that they did something, even though it didn't get passed.
The next one, if you're anything like me, you have no faith that the United States healthcare system is going to fix itself. And you're desperately hoping artificial intelligence will somehow do its magic and fix it. And as we all know, the power of AI has been increasing, and just in the past 6 months, it's really gone mainstream with a particular set of models made popular by ChatGPT. So everybody is just about using this now. It's not cool anymore. It's not hipster to be into AI. It is boring. It is mainstream to do generative AI now. And I was into AI before it was cool, just saying. Now's where it really gets interesting. So for crusty old school AI fans, one of the things we've been waiting on, particularly for the past 20 years, is this inflection point where so AI is exponential. So it doesn't go, straight up. It goes, parabolic. Like it's flat for a long time, and then it goes almost like, directly upward. And it's really hard to predict when you're in that like little, kind of the little thing. But once it's there, once it goes parabolic, I don't know what this is, but like once it goes parabolic, it's like over, like it's like too late. So a lot of the AI safety people on Twitter, and God forbid on LinkedIn now, are basically waiting for that moment where they go, see, like the AI is too powerful. It's, we screwed up. You should have listened to me when I was an AI hipster, and whatever. So, so now we have a paper that I think is a really big deal, and we're going to try and explain it with an analogy that's going to go poorly, but it's a really big deal. So Mike, have you used ChatGPT?
In terms of actually training models, doing prompt engineering, that's my experience with ChatGPT. I haven't really used it. I'm so used to like traditional old school Google searching and trying to figure something out on my own that I'm just never really think to ask a robot a question or give me an analysis of something.
Okay. That's like very rustic of you. So the GPT that you
More
did
traditional.
use, it's like very conservative. It's so the the GPT you did use. Do you remember which one it was?
GPT 3.5.
3.5. We tried to make an analogy to make this interesting. We tried to make an analogy to IQ, and people have used these GPTs on IQ tests, and they come out with numbers, but it's not real human intelligence. We think that number is confusing. The number that computer scientists use to describe these models is something called tokens. And a token is basically a syllable. So my name, Ryan, is about 2 tokens. Michael's name, Michael, is about 2 tokens. Michael Martinelli is about 5 tokens. Okay. So you can think about, the average word is like 1 to 3 tokens. And the current models you referenced, so GPT-3, you had 4,000 tokens. So it could remember 4,000 tokens or about 2,000 words of context. The current hot model, so the one you have to like pay $20 a month to OpenAI for, has 32,000 tokens. So it can remember about 16,000, like a short novella. And the research paper we want to share with you is about something called LongNet. And there's a lot of technical details in here, which we tried to digest, but I don't think we can make it quick. Long story short, LongNet uses a different layer called attention on top of otherwise traditional software, traditional for this domain, to achieve far more tokens. Mike, how many tokens do you think would be a reasonable evolution if we went from 4,000 to 32,000 in the past year?
Um, 100,000.
100,000? That's a pretty good guess. Yeah, at least 100,000, maybe, maybe we get surprised. It's a million tokens, right? LongNet, however, and this is research by Microsoft, so this is like stuff they're trying to get into production and ship out to you as a consumer in the next couple of years. LongNet claims they can do 1 billion tokens. There's not a really good way to conceptualize how much more powerful that is. So we tried to do some math, and if you use the analogy of words, you could read about what GPT-4 can do today, 32,000 words. You can read that in about an hour, a little less than an hour, okay? LongNet with 1 billion words would be the equivalent of reading constantly for 15 years. So I don't know if that is a wow for you, Michael, but that broke my brain. So we really don't know where this is going. The AI safety people are soon going to be posting this all over the place. If you are in healthcare and waiting for something that's even more compelling, but also potentially more dangerous than GPT-4, it's on its way, is the gist here. And how data gets handled and how these things consume, private health information or medical diagnostic information is still largely unsolved, and there's a huge need forming. Mike, do you have any ideas as an attorney how you would think about the handling of PHI?
It wouldn't be PHI, health information that's de-identified. When you're using these types of models that are really getting into detail, like into your health data, you don't want to risk having that association, so a personal identifier with the health data, because it'll inevitably lead to a unauthorized disclosure. So you have to be very careful about the data, making sure it's not identifiable to a specific person, healthcare data. So then it wouldn't be considered PHI.
What we need as a society would be to get this efficiency into use cases where the data is identified, right? Medical billing is the one people talk a lot about now. So I go to the doctor, I get poked, I leave my insurance card, they charge some billing codes to my insurance company. My insurance company 2 weeks later pays the doctor $500. So that revenue cycle that most doctors and hospitals have sucks right now. It can be really slow. There's a lot of denials. It's kind of a cat and mouse game between the insurance companies and the doctors about what they will and will not cover. And you see this a lot with prior authorization. It's really hot with Ozempic and Wegovy and all the semaglutide right now, where every American would love to be skinny with just a pinprick. So prior authorization requests are through the roof, and there's a huge demand to automate prior authorization with AI. However, the insurance companies don't want to pay for this. The reason you're getting denied is it's freaking expensive. There's not long-term economic data, and Any Google search would tell you that it's largely people searching for vanity rather than diabetes prevention. So I'm the average citizen. How should I care about my medical record, my colonoscopy, my therapist notes about depression ending up embedded in one of these giant models, particularly if the model is going to be super intelligent?
Well, first, I wouldn't have the same concern about the therapist notes, because that would be psychotherapy notes under HIPAA, and that would have to be segregated from PHI, in terms of the health data. I mean, nowadays we see major health institutions having data breaches all the time. We hear it in the news almost weekly. So I think I mentioned this in a previous video recording we had, that I personally expect at some point that my health record or some information from it is going to be disclosed to a malicious actor. I mean, it's inevitable. With that said, because you're so for me, because I'm so desensitized at this point, I probably won't even think about worrying, 10 years down the line when AI is learning everything about my health from all of the medical records I've ever had. So I'll already be back, it's out there already. What am I going to do?
Wow. Okay. That's a pretty cynical take. I thought you were going to go with something different. Why wouldn't therapy notes end up in there as well? 5 years from now, if I Google my boss, should I expect to find out that he told his therapist he cheated on his wife? Is that what's happening?
The language model would have to specifically be going after those psychotherapy notes, which are not part of your actual PHI, your health records. If you go to the therapist, say psychiatrist, and they have notes on abuse or something, and then they also give you, medication, which is your treatment, that medication component and the dosing and everything, that's PHI. That's part of your medical record. That has to be segregated and kept separate from the notes that are taken during that session. If you're worrying about it, it's because somebody was behind that model who had not the best intentions in mind, because that's the reason that HIPAA has an extra layer of security over that, is because of the sensitivity of that information.
I see. So you're saying that everything would just get breached, though?
Yeah. Well, when you have a data breach, you could probably count on your one hand the amount of times, if any, that you also saw psychotherapy notes involved in the breach, because when they go have a data breach, they want to get the PHI because that has the identifiable information that they want, especially social security numbers. That's not going to be in the same batch of information as the psychotherapy notes. What can a malicious actor, say in Russia, profit from having somebody's psychotherapy notes, aside from they want to blackmail somebody that they know?
Epic is working with Microsoft on embedding this type of AI on top of Epic. The Epic is the leading medical record system, particularly used by hospitals or inpatient settings. Multi-billion-dollar companies. They're trying to bring this technology to every existing Epic instance. HIPAA was designed in 1996 for health insurance processing. There are updates coming now, but it still doesn't really conceptualize your medical records being embedded in an AI and then that embedding leaking into other use cases, right? Unless the AI was run in a way that could be disposed of, it didn't attach back to the main system.
Even this would be specifically relevant to the security rule, and even though it doesn't specifically say anything about AI, because it was written before AI was really a thing, something that was mainstream, it does set the groundwork or the framework for how you would approach that. It has the minimum requirements that you should have in place to protect PHI, electronic PHI, EPHI, and you just have to use that guidance and use those regulations to know what the boundaries are in terms of how you could use the AI. Yes, I'm sure that eventually, if that does happen, if this starts to be something that's used, like say Epic and Microsoft did have a merger, Congress would take note of that and attempt to amend or add some amendments to the HIPAA security rule, especially if there's results in a huge uptick in breaches or unauthorized disclosures. But I don't think you don't need specific HIPAA regulations specifically for AI because the general framework is already there.
So is there anything that is very clear in your mind that you're visualizing is inevitable?
I'm assuming it would definitely have a use case in order to increase efficiency and reduce costs. If you think about it, we were talking about earlier in the insurance context for prior authorizations. So if you have the first general round of screenings, you get that denial the first time. That was from an AI model, and then you can appeal that to an actual human. I wouldn't keep using AI models for those further appeals, but that's one less. The first round of prior auth you're getting from everyone to get a certain medication procedure. Using AI instead of all the individual peoples whose current job it is to review those prior auths. It's taking jobs, but it's going to be less expensive for the insurance companies.
This is very popular to fund AI for prior auth, so it's definitely rolled out. I think the thing I'm trying to predict is, do we see any positive or negative outcomes of this? Or hopefully the ideal scenario is our lives just get easier, right? Things happen faster, more predictably, for less and less cost over time.
Yeah, I can see say right now you have each prior auth case is handled by a human being, and insurance companies do have standards set in place. There should be criteria, uniform criteria that an insurance company says these reviewers must use in order to either accept or deny the prior auth. But people differ in their judgment. If you have one model that you train with a specific set of requirements or criteria in terms of looking at prior authorizations, I think you'll see an overall uptick in denials for that first round. Then if you see an uptick in denials, there's going to be an appeal, and that's going to require, I believe that obviously the appeal shouldn't be handled by AI. That would be handled by a human. If you think there's jobs lost, it could be a wash. We have to see how it turns out. There's so many, and such a large increase in initial denials that it's just the cost is going to be off put by the extra people you need to hire to do reviews. Then that could be an interesting outcome there. Before that would happen, I imagine you tweak the model.
All right, let's move on. Kind of wrap it up quick. A couple interesting updates, kind of related to that, is but really just more in the groundwork of healthcare. Is the classic thing is it's summertime. We're talking about going to the shore. My cousin, when we were kids, got an infection while we were at the shore. The wrong type of antibiotics can kick off a cascade of really horrible things in your digestive system, leading to dehydration, and it can be potentially fatal. So in that scenario where you're away and you have to go to the hospital, that doctor who's seeing you urgently doesn't have access to your medical records, and they might prescribe the wrong antibiotic or antibiotics instead of something else because you have a predisposition. That whole thing is the jargon for that is obviously interoperability, if you're familiar with it. And what is absolutely missing is a common agreement for passing these records around between hospitals and clinics to hospitals, in and out of different systems. And that is a real tragedy and has not been handled or managed. And there is an update this week to something called TEFCA, or a commentary that came out, an interview with a guy who used to run the office in the federal government who oversaw this stuff. He's saying, stop dragging your feet to these old school hospitals, because they want to do this more procedural, paperwork heavy approach to this, and instead use this thing that is a more modern data standard, right? And our whole world is made more convenient by modern data standards. It's should be obvious. It's weird that we have to fight for it in healthcare. The thing is called TEFCA. It's super arcane. I think it's intentionally made boring so people can push it off and procrastinate on it, because it's impossible to digest and get people to adopt. But I'm personally on the side of this guy. I think his name is Dr. Ricker, because he's saying, just make it modern. Like, use the modern data standard we've invested this last decade developing, so that you can send a medical record as safely and reliably as like sending an email. And that's a no-brainer. I'm curious, do you have any thoughts?
Yeah, I mean, you could even incorporate the AI discussion into this, because maybe, correct me if I'm wrong, given my not so technical understanding of inner workings of this, but in order, like, this involves transmitting information between two providers. Say I'm at the shore and I get bitten by a shark. Shark Week coming up, we have that theme, and I'm losing blood. I'm unconscious, and I get taken to like Atlantic City Medical Center or something. I can't talk because I'm unconscious. I'm losing blood, so that's a traumatic situation. You need urgent treatment. They have no way of knowing like what medications I'm on, if I have any like allergies to certain medications. Obviously, they can't tell my blood type, ask me my blood types. They're going to have to give me like O neg, but also they wouldn't have any knowledge of like surgical history or anything that could be relevant. So they're just kind of going blind, and in order for that like to fill that gap, they would have to have someone from like my provider, like from their medical center, receive information from my doctor at home at Penn. I'm assuming for this purposes of this, I'm going to say they use two different EMRs. So it's not like you have two hospitals with the same EMR where those are interoperable. It's much easier when you have like Epic, for example, Care Everywhere. That's like how I think of the ideal standard of like
another monopoly, though. Another corporate monopoly. Yeah, I'm sure Epic would be happy to send your records everywhere that a hospital wants to pay $100,000 a year for a license.
Yeah. Right.
Yeah.
Yeah.
All right. Well, okay. The next one is healthcare is very political, obviously. You spend like $1 million, and more than a few people want a single-payer healthcare system. And there's a resurgence, which we covered 2 or 3 episodes ago in California, to get a single-payer system just in California. And it leads to increased tax burden, but could have all of these downstream benefits, all the things people advocate for in single-payer. So this article, which Mike dug up, speaks to justification for going with single-payer in California, but it's a health affairs article on individual market for health insurance, and specifically in families on the poverty line.
They looked at just California residents, a cohort of California residents that were, they had 3 cohorts of people in different below the federal poverty level, and it looked at the American Rescue Plan, which is a large spending bill. There's many different aspects of that aren't related to healthcare, but part of it was additional funding to states to help subsidize health insurance and cost sharing for people in lower income tax brackets to help them afford private insurance. So what they looked at is they compared in 2017. They looked at people who were buying their own insurance. so they didn't get it through an employer, and they looked at the different metal tiers. So there's bronze, which is the lowest, silver, and then gold, which is the highest tier. And in 2017, I saw about, I think it was 40% of the people below the federal poverty line in California reported having difficulty affording their premiums for the highest metal tier, which is the best plans, the gold plans. And then they looked at, again, after this American Rescue Plan was passed and the subsidies went to California, they noticed that only there's a 28% of that cohort reported difficulty in affording those good gold plans for purchasing individual insurance. So what they found, they noted, they see a correlation between having that additional federal funding coming into the state to help the state, which is already giving funding and subsidies to the low-income individuals to help them purchase their own private insurance. So basically, taking a step back, like this is like an alternative approach, you could say, to universal healthcare system, a universal system in which people still have the ability to choose like what tier level plan they have, because everyone's health needs are different. And universal, it would tend to be a one size fits all. It would be like the same plan that everyone has. So this is kind of looking at it, it doesn't go into talking about a universal system. So we're just speculating on how you would compare this to that policy.
It's helpful, I guess, if you're designing a policy or seems pretty predictable. If you give people money, they're going to choose the better thing, but maybe you have to confirm that, I guess. All right.
Yeah.
That's all for me in this episode. Mike, thank you for being here, as always. And that's it. Cheers. See you, everybody.